So I guess I don't have to introduce myself, but one thing I wanted to do before I started was just thank everybody here for being really awesome and accommodating, especially Paul Gustafson, who's kind of taking me under his wing at BC Children's, so thanks a lot, I really appreciate it. And then, I don't know if you've noticed, but I've actually put urosurgery up here because I'm championing the movement to change the name of our specialty to urosurgery. So we stopped getting nephrology consults or neurology consults, and then also people realize we're actually surgeons too. So this is actually just a joke. I'm known in Edmonton to be kind of long-winded, and so I put this up to raise the blood pressure of everybody when I was giving us this talk. And then, again, same thing. It's not 120 minutes. It's going to be like 40 minutes or something. But people actually would gasp in the audience when I did it. So the things I'm going to do basically is first talk about, this is all about antenatal hydronephrosis, and then so I talk about the background, the diagnosis, and then actually focus on the number one cause outside of the transient or the physiologic one, which is the UPJ obstruction. And then I talk a bit about the pathophysiology and from what we know from human studies and pathology, and then what we know from animal models as well, which is actually really interesting. And it's kind of neat too because it's sort of an area of translational research where it's not focused on cancer, and it's actually really neat to read about. And then finally looking at what does the lack or the evidence, and basically what I'll show you is kind of the lack thereof, guide us to do so far. And so, quick review, embryology review. There's three renal kind of systems. The pronephros and the mesonephros was kind of involute time, but the pronephros giving rise to the mesonephric duct. And then basically there's this metanephric blastema, which is sort of like, you can think of it in this picture as the black stuff. And this is actually just a little fluorescein radio-labeled, sort of pictures of a rat kidney in development. And this is amazing because it's only over like 90 hours or something, so that's how fast this sort of arborization pattern happens. And then the most important thing basically is that there's these two tissue types that sort of meet and they mutually induce each other. So you get the ureteric bud, which is giving sort of rise to the collecting system, the ureter, the pelvis, the calyces, and the collecting tubules. And then the metanephric blastema is giving rise to the nephron. And if there's any integration problem with those two mutual inducing processes, then you get sort of the hallmarks of dysplasia. And I'll show that in some of the histopathology. And so this is just, I think it's out of Campbell's, but basically, again, there's that fluorescein kind of labeled diagram on the left. And if there's normal development, then you usually have about 1 million nephrons at birth. And if there's any issue in that process, you actually end up with kind of the hallmarks of dysplasia, both on imaging, which really doesn't project at all. That's kind of terrible. Hopefully the other pictures are better. And then there's the histopathology slides. So, and I'll show you a lot of stuff about that with the basic science. So in general, congenital hydronephrosis is the #1 cause of renal insufficiency in boys under 1 year, and a big reason why we do pediatric transplant. And antenatal hydro is really common. It depends where you read, but in the CUA guideline, I think it's like 1 to 2%, sometimes higher. So it's pretty prevalent. And then of that, though, the problem is that only 20% will become clinically significant. So the vast majority aren't. And so there are some risk factors early on that kind of tell you that there will be some urinary tract abnormality. And earlier hydronephrosis, so when it's seen on the second trimester, especially over 7 millimeters, and I'll show you some pictures of this, is more likely to be significant. If you discover the hydronephrosis in the third trimester, it's usually transient in 40 to 80% of renal units. And then again, the AP severity is kind of how it's graded, and I'll go through that again down the road. And then as well, if there's corresponding oligohydramnios, then that indicates a degree of severity as well. And so just looking at the sort of what does this end up being down the road, this is just a good differential that everybody has in their mind, but interestingly enough, transient and physiologic is the overwhelming majority. And then the UPJ obstruction, which I talk a little bit about because there's a little bit of the evidence around that. And so there's going to be a focus on that. And then vesico-ureteric reflux, megaureter, ureterocele, multicystic dysplastic kidneys, and posterior valves. And what's interesting about this is I just looked at like 150 antenatal hydro cases basically, and then it actually fit well within this breakdown, which is kind of neat. So it seems to hold true. So the significance of this problem is, and this highlights sort of the extreme of it, is that this is in a cohort of sort of the posterior urethral valves, but poor prognosis. And this was in pediatrics, kind of in 2001, and basically, it was alarming because 70% of these kids were in end-stage renal disease by 11 years, and this was after they had the opening of the urethral valves. So the problem it's a pretty big problem. And so I'll just quickly back up and talk a little bit about ultrasound and how it came into being in this use. basically in the 40s, there was a guy, Dr. Carl Dusek, who sort of started using it on brain imaging, and then in the 70s, it was discovered that you could see fetal genital urinary abnormalities. And then in the 1980s, obstetrics began using it, and they noted that about 50% of the things they were finding were renal dilatation or some form of renal anomaly. And so remembering that the prevalence is about 1% of fetal ultrasound, it became a huge sort of problem in a way that we were discovering this. And then so in the New England Journal in the early 90s, they actually did a paper, they did a study to see if does this actually even make a difference. They took low-risk women, and they offered them screening ultrasound versus only if it was medically indicated, like there was a problem in the pregnancy. And their conclusion in the early 90s was that this made no difference in what was a standard 5% adverse perinatal outcome rate. But when you look at the outcomes, they were all sort of on the most severe form of like fetal death, perinatal morbidity, and nothing really looked long-term. And so a lot of the sort of kidney problems were going unappreciated, I guess, in the sense that we were finding them. And then subsequently, so for urologists, kind of concern became, well, maybe we're just going to find a ton of these ballooned out kidneys and hydronephrotic kidneys and then be doing way more surgery than we need to. But this was kind of a neat study because this was from 1982 to 2002. So it sort of encompasses I don't know where that show up. Around sort of the early 90s is where ultrasound became basically like a standard of care in obstetrics. And so you can see that there's actually no net change in this timeline in the amount of pyeloplasty repairs that they were doing. They were just noting that they were doing them earlier. So instead, you can see the numbers here, 94 to 156 under 1 year, so less later on in life. So there's kind of a change in the pediatric urologist practice in a sense, because we're discovering this now and not waiting for symptoms or signs. So then, I guess in order to go on, you have to kind of know a little bit more about what's normal, because it's all about kind of fluid levels and in the ultrasound. So basically, by 14 weeks, the amniotic fluid volume becomes predominantly urine, and then before that, it's this transudate of the amnion, and then with that, the placenta is acting as this like in utero dialysis machine. And so for that reason, you actually rarely find oligohydramnios before the 20-week ultrasound, or the 14 weeks, sorry. And then subsequently, that's kind of why the timing is around 20 weeks for the ultrasound. It sort of corresponds to the normal development and sensitivity for finding abnormalities. And so at that time, when you do one, at about 20 weeks, the bladder emptying is about every 30 to 60 minutes. And so you should be able to see that if you wait long enough. And at this time, around 20 weeks, 100% of normal kidneys were identified in one study. And so if there's any abnormality, like severe hydrourea or hydronephrosis, it can be seen as early as 12 weeks. And so this is just a view of what's normal. Oh, this is totally horrible, isn't it? There's 100 pictures like this right now. Well, that's too bad. But basically, this was normal. It's really bad, isn't it? Yeah. So what I was going to show, basically, this was just a normal axial section or transverse view. And the kidneys, there's basically no hydronephrosis here. And this is kind of a standard view that you see on the prenatal ultrasounds. As is this. This is just showing the longitudinal axis of a normal kidney. It's too bad it doesn't project. Oh my god. Do you know, is there any way we can change the... There's some really good pictures, it's too bad, but... Okay, well this was just another picture just showing some bilateral hydro. You can kind of see the little arrows, the green arrows up there, but how they've measured it. But this was in a second trimester. And then one of the things is even earlier than 20 weeks, it's very, very difficult to even see the kidneys, and again, this doesn't help. But then when you looked at this, it was just this homogeneous kind of, looked like a snowstorm kind of thing, and it almost looked like there was nothing there. But when you put the Doppler on, you could all of a sudden recognize common vascular anatomy, and so that was sometimes a good way to find the kidney. Oh my, this is terrible. Okay. Well, basically, so at 20 weeks, the kind of magic number, I guess, to know about is 7 millimeters. There's grading mild, moderate, severe, just like there is in the third trimester ultrasound. But the sort of prognostic significance isn't really well established, except that it seems like anything over 7 millimeters in the second trimester becomes significant, and that would sort of correspond to being in the moderate category at that time. And I'll show you a study that kind of, there aren't very many studies looking at second trimester ultrasounds, but I'll show you one that sort of correlated that to the likelihood that you would require surgery for that if it showed up that early. Remember we talked about earlier antenatal hydro being sort of a risk factor for a problem, an anatomical problem down the road. And then this is just severe. I think even with the horrible projection, you can see that this is a 20-week ultrasound where there's severe bilateral hydronephrosis, and that's pretty early and probably very significant. And so when we grade it, there's kind of two different grading sort of schemes. One is the easiest, which is the AP diameter, and that's on the transverse views. It's kind of like the lower pictures here. I just did this study where I measured like 150 of these, and you just bottom line is to make sure you're not measuring an extrarenal pelvis. You just have to make sure that you make your measurements where there's parenchyma on either side. Sometimes one of the confounding things here is that a lot of things were called hydro, but there would be an extrarenal pelvis, and if you actually did the measurement properly, it would be normal. And so that's the AP diameter, and there's severity, which I'll go through the little chart in a second. And then that's all the antenatal. Usually on the ultrasound reports, the prenatal ultrasounds are always reported in AP diameter. And then once the baby's born, it seems like we switch over to using the Society for Fetal Urology grading system, which is kind of at the top here I'm going to show you. And so grade 1 is just that there's mild splitting of the pelvis. And then 2 is mild splitting of the pelvis with pelviectasis. And then some say not, one or fewer calyces, so very, very minimal calyectasis. And then 3 and 4 are where it becomes significant, especially when you're talking about obstruction. And this is kind of reflected in the CUA guidelines as well. But 3 would be that you've got pelviectasis and you've got calyectasis, but you don't have any cortical thinning. And then that's the difference between grade 4 is that you've got hydro, and then you've got calyectasis, and then you've also got thinning of the parenchyma as well. So 3 and 4 become most important prognostically in trying to determine if there's pathology here. 1 and 2 tend to actually resolve, and I'll show you the data around that if we don't do anything. And then most importantly, it's kind of there's actually never really been a study that's correlated the SFU grade with actual renal function. And that's important because when we look at how do we pick who needs surgery, that becomes kind of tough. And I'll show you the downfalls with the different types of technology that we use. So this is just a study looking at, this is sort of one of the few studies in second trimester looking at the likelihood that you would need surgery if you had an AP diameter greater than 7 millimeters identified. And so the bottom line here kind of is just, I've circled it here, but 32% of these patients went on to require some sort of surgical procedure. So quite a bit actually, you see a third, that's pretty significant. But usually we rely on the third trimester, and so the second trimester utility is basically just picking up the severe ones, and it changes the follow-up. They'll go to having ultrasounds every few weeks versus a third trimester if it's normal, and so the intensity is different. And so, but then if you look at the third trimester ones, this is kind of the magic numbers, I guess, for us to know, because you see it in a lot of the literature, but mild is everything under 9 millimeters AP diameter, moderate from 10 to 15, and severe over 15. And this actually is kind of important because it does correlate with the likelihood of finding pathology. So in that differential diagnosis I presented, probability that you'll find something there, not just transient or physiologic, goes up immensely when you look at the different categories. So from 12% all the way up to almost 90%. And then importantly too, in this group of people, the degree of the AP diameter sort of split doesn't actually correlate to the reflux risk. It's just a constant 8.5 to 15% in all these studies. And so that's the importance of VCUG and not relying on ultrasound to try and establish is there reflux going on. So I just put a quick slide in here. This is something probably no one's ever seen. I looked at like 150 of these and not one had this or was a product of having intra-uterine sort of therapy. And this is basically just like a fetal suprapubic tube. And so it's a vesical amniotic shunt, best in valves or urethral atresia or something. And there's actually no good evidence that doing this improves renal outcome at all. You're only doing this to increase the amniotic fluid volumes and hopefully get better lung development. And so most of these people, though, if they need this, it's a very poor prognosis. 2/3 require renal replacement almost immediately. And so when I talked to the guys in Edmonton about this, they said, we don't even really do this. We actually would focus more on counseling for termination. It's probably the better discussion to have. And he said this is a classic example of one of those things where just because we can doesn't mean we should, kind of thing. But it's an interesting technology, and it has worked before. But just to mention it quickly. So I guess, so you've made the diagnosis on the antenatal ultrasound. Obviously we need to follow these people, and so this is kind of a question I get asked a lot is, we see this a lot where an ultrasound is done within like 24 or 48 hours, and this was just a study that looked at probably why you shouldn't do that. And so they took these people as 37 renal units. They all had an AP diameter of 8 millimeters or more than 8 millimeters. So they're almost in the moderate category. And they basically did an ultrasound at 48 hours, and they repeated it again at 7 to 10 days. And if you did the ultrasound at 48 hours, you actually missed 38% of people that would go on to worsen or have increased hydronephrosis. So your false negative rate was pretty high. And so that's a little data. It's actually, and then actually almost over half of those would worsen into a higher category of severity. So now and it's kind of well established now, and we know that we should wait, if we can, at least a couple of days. And then the theories behind that are that there's a relative hypovolemia when you're born, and also the kidney, it takes a couple of days for the kidney to start making adequate urine production, so the pelvis might not be as full. And then the next thing is, the next test we're used to ordering is looking at the MEG3 as well. And there's not a whole lot of good quality studies, but basically there's this consensus, and it's reflected in the guidelines too, the CUA guidelines, that you should wait about 1 month of age before you rely on the findings of a MEG3 scan, and probably just related to fetal maturity, but this is just basically expert opinion. So that's just the timing of it. And then one of the other controversies around the MEG3 scan is the accuracy. And so drainage shouldn't actually be used as the sole basis for who needs a pyeloplasty or who's obstructed, because there's significant drainage variation that's related to the technique. And so this is where the whole well-tempered renogram kind of comes into play, where they're hydrated, they have a catheter in there on their back, all of these factors to try and minimize that. But when you read the paper, there's one by Gordon, it's actually quite significant. And then the variation in differential function that we measure also varies quite a bit, from 5 to 10%. And that's a lot, because sometimes if we saw a decline by 10%, you might be encouraged that you need to do something. That could be within the margin of error. And so it's even worse if you're under 1 year of age, which is when we tend to focus on this. And that was found in about 25%. This variability. And then as you get older, that variability seems to lessen. So that's kind of the reason why you do the MEG3 scans. Sometimes you have to take it with the clinical context as well, because it can be misleading. And then so looking at the CUA guidelines now, this is just them summarized in a few bullet points. But usually if you know about this consult antenatally, you've usually established that it's a solitary kidney or that it's bilateral or severe. Those are the two special circumstances where these people should, if they're stable enough, should wait and have an ultrasound before they leave hospital, but after 48 hours to increase the accuracy. And then otherwise, though, in everybody else, it can be any time between sort of that week that we saw in that study to 30 days. And then one of the most important things is just when you're talking to them is to know that there's no point in delivering the fetus early for this reason. If it's found, that's kind of like a common question we used to get in the clinic, in the antenatal clinic, and then they know that now. But basically, remember that the placenta is this in utero dialysis machine. So actually, the baby's probably better off being in utero and for lung development and other issues. So if you suspect bladder outlet obstruction, then a VCUG should be done before leaving the hospital in the case of severe bilateral obstruction. A VCUG is sort of non-urgent. We talked about the evidence behind waiting a month, which is basically just expert opinion, but it makes sense. And for people who have, this is just lots of indications, but a dilated ureter, a duplex kidney, if there's abnormal echogenicity or an abnormal bladder, anything that raises your suspicion that there's reflux at play, then a VCUG at 1 month is in the guidelines. And I'll show you the evidence for this too, because that's kind of thing. The evidence is sort of kind of weak in a sense. It's sort of like, in my opinion, it's kind of like, oh yeah, you could, I guess. That's cool. It doesn't really say like you need to do this. It's like C and D evidence, and so I'll show you that. The MEG3 scan as well is about a month as well, and there's a discrimination in the guidelines, basically looking at the SFU grade. So if it's 3 or 4, then your sort of bang for your buck in doing this is going to be a lot higher, especially if it's not explained by reflux, which was a preceding test that you did. So this is just a quick algorithm showing that. And the whole point here is just to show you that antenatal hydro, we get the diagnosis. Antibiotics, because that's always a common question. I did a little research thing on this, looking at in our center what was the rate of infection, and it's grade D evidence, which is basically saying like we don't really know. You can, you can't. It's not really. We don't have evidence to say, and that's kind of what we showed as well in Edmonton. We don't put anybody on prophylaxis unless it's obviously severe bilateral reflux, and then sometimes we do, but that's the only case. And the infection rate was really low as well, so it kind of corresponds to what I'll show you in the literature. And then the distinction seems to be the SFU 2 and less, and 3 and 4. And so if you look at the VCUG as your first workup, and then if that's negative, you get a renal scan, is grade C evidence, even when it's pretty severe hydro. And then if you look at SFU less than 2, or 2 or less, it's grade D evidence to do this workup, presuming that they're not having infections or there's any other indication. I guess it's sort of up to the clinician. And so this is just showing you what that means again. So grade D, like there's no recommendation possible because of inadequate or conflicting evidence. And that was sort of the evidence behind the workup for grade 2 and less. And then even if it's grade 3 or 4, it's sort of majority level 4 evidence, and then maybe some expert opinion. So it's not the strongest. There's no real level 1 evidence. In fact, the only thing that was level 1 evidence in the guidelines was the ultrasound that you do afterwards. So the big conundrum then is sort of, well, how do you predict who's going to progress? You've made the diagnosis, and then you have your workup, and then so we can diagnose that maybe it's one of the differential causes, one of the obstructive causes, or it's reflux. But how do you predict this? How do you predict who needs surgery? And so the problem is that we don't really have a perfect tool or test. Creatinine is sensitive, and it's too late. You've missed the boat pretty much by the time it's gone up when you're following people. And as I showed you earlier, ultrasound doesn't actually correlate with renal function. So we sort of tend to use it in the clinic, or from what I've seen, we use it if people are doing fairly well. We use it as a screening kind of thing. If the ultrasound is worse, then we might go and do a scan, like a renal scan. But otherwise, radionuclide imaging has its issues as well, which I showed you in terms of the variation that you see. And then MRI, there was a lot of stuff when I was going through this, initially looking at MRI, but it's kind of the hype around it has faded because it's expensive, it's really hard, it has to be sedated, very still, takes a long time, and it didn't really add anything to the above three tests. So it's still actually kind of a bit difficult to determine who's going to progress. And then the ultimate goal, the reason you want to figure this out, is because this is what you're trying to stop, and this is dysplasia. And this is only at 28 weeks, so this is pretty severe. It's bilateral, and there's the hallmarks on the ultrasound. So very echogenic cortex with, you can see little cysts everywhere, thinned cortex, and then there's lots of hydro. I'll talk a little bit more about what that would look like on the pathology slide in a second. But at the end of the day, understanding dysplasia, I kind of had to wrap my head around it because I always just assumed it was similar to like an adult kidney when you had an obstruction and it got, there's some hydro and it thinned a little bit. But that's just atrophy. That's not actually dysplasia in play. And so the difference is that in order to have dysplasia, you have to have a developing kidney. That's the key. And so in kids, when we see this, it's more severe. And it's because at the end of the day, they just don't develop that nephron mass. Remember that one slide where they had 1 million nephrons? They're way below that. And so it's unique to congenital obstruction. And one of the interesting things is that multicystic dysplastic kidneys are actually now thought to be probably improper canalization around 8 weeks of gestation. And that gives you that clinical picture with that very dysplastic kidney, which should involute in time. And so more on dysplasia, it's hypoplasia, not just atrophy. And that is that the tissues actually never form properly. And so it's a development failure. And then the development is basically this culmination of, it has to grow, the kidney has to grow, but it has to differentiate as well. And then the extracellular matrix is very important. And in dysplasia, there's a lot of fibrosis, and that messes everything up. And then because of that, there's a lack of functional integration among the different parts of the kidney. So they can't concentrate their urine, they dump renin into the blood, raising the blood pressure, they have proteinuria, and it's kind of causes infection as well. So basically, at the end of the day, you can just say dysplasia is disorganized structure with primitive forms of renal tissue. And this is kind of what it looks like on some of the pathology. This is, as time goes on, the severity gets worse. So the earlier the obstruction, the worse. And there are little cysts. This is kind of all the hallmarks again. Little tiny cysts and dilated tubules. And then this is the severe form where there's actually cortical thinning and then hugely dilated collecting system tubules. This is looking at sort of some of the animal models, because this is really hard to study in kids because the kidney is developing in utero. And in order to induce dysplasia, it's been shown that you have to interrupt the function of the kidney within the first half of gestation, or kidney development. And so you can't really do that in utero unless you do fetal surgery to do that, to study it. So we've turned to animal models, and there's a bunch of work, there's tons of work done with sheep, which is kind of neat. And this is basically, they do fetal surgery in a sense, but the sheep are big enough that you can do it. And then for us, the sort of 4 hallmarks of renal dysplasia that have been elucidated through this is that there's these random cortical cysts, which we've shown a bunch, architectural disorganization, inflammatory infiltrates, a decreased nephron mass. But the 2 that kind of I didn't know about, kind of neat, is that metaplastic cartilage is actually seen on the pathology slide, which is kind of cool, in 30%. And then the thing that's pathognomonic and unique to humans is actually these fibromuscular collars. And I just remember I talked earlier about how there's the ureteric bud and there's metanephric blastema, and they basically grow together and mutually induce each other. It's the metanephric blastema that actually, which is developing in the nephron, that actually causes a regression in muscle that's surrounding the tubules here. That's this brown stuff. So this is alpha smooth muscle actin, and this is in normal. And then this is a two. Obviously, this is the one there's obstruction. It's dilated, and there's this layer of smooth muscle around it, which should involute in time. So that's one of the pathomnemonic kind of hallmarks, unique to humans. They couldn't reproduce this in animal studies. This is kind of a cool study. Doesn't project well, but this is one of the earlier studies looking at the compensatory growth. So this was in rats, and this is 2 rat kidneys. Rats are great because 90% of the nephrogenesis takes place within 10 hours after birth, but after birth, so you can actually, little rat pups or whatever they're called are delivered, and then you can induce an obstruction, and you can basically watch within days. You can induce dysplasia in them, so it's an easy animal model. So they did this here, and so this is sham surgery. The kidneys are normal. This is actually, the left is the one that they obstructed for 5 days, which is a significant amount of time in kidney development for a rat. And then they undid the obstruction, the ureteric obstruction, and you can see that there's some dysplasia, but also the other kidney has actually undergone compensatory growth. And then if you didn't relieve that obstruction, the other kidney just got much bigger. But the neat thing about this study was that they actually showed that the functional renal mass actually stayed the same. So there's some sort of regulatory mechanism here in terms of functional nephron mass, and it tends to correspond. It tends to be the same weight, which is kind of neat. And so we see that on ultrasound when we're following people, and if you're wondering if this obstruction is significant, if you look at the other kidney and there's compensatory growth, then it's probably pointing at the problem. So the shortfalls of human studies are basically that we have no way of knowing when the obstruction is actually occurring, and where in that process or where in that timeline does dysplasia kind of come into effect. And so we needed a good animal model for that. And these are just a couple of the animals. There's a whole bunch that have been used, but the rat and the sheep are the most common. And the rat one's just kind of neat because if you look at the period of nephrogenesis, it actually continues on right after the period of gestation, which is the white little box. And so it's a perfect model, and then sheep are just big enough you can do fetal surgery. And then in humans, just an interesting fact they've figured out that unless you cause the obstruction for the first half of gestation, you won't induce dysplasia. Just like adults, you'll get hydronephrosis and atrophying as a predominant kind of histological finding. So I just talk a little bit now, knowing that, a little bit about sort of the translational research or the neat stuff in the literature, which none of this is in the guidelines and none of this is in effect, but it's just neat to think about because they're kind of making some progress. And one is looking at growth factors, and the second is TNF-alpha blockade. So they know that when you have obstruction, there's a decrease in growth regulatory genes, and that translates into fewer nephrons, delayed maturation, and increased apoptosis. And there's a study looking at rats, and they gave them epidermal growth factor, and they showed that you actually reduced tubular atrophy by 50%. You decrease that smooth muscle actin, that brown staining that I showed, so that it's mutual induction is in play, and then you actually decrease collagen deposition by 50%. So it's pretty impressive. And then this is another study looking, this is totally horrible, looking at TNF-alpha and what's its effect. And this is interesting because we have a lot of drugs that target this. So if you look at like rheumatoid arthritis or any autoimmune diseases, there's Humira and infliximab and those things that are, I was reading it was a $25 billion industry, so it's huge. And the bottom line is that this is the end effect in the cascade of inducing apoptosis. So what this first thing was just showing you normal tubules. The blue are the little nuclei. And then this one was showing you a ballooned out tubule. And there's actually this red staining everywhere. And that was actually cytochrome C that comes from the mitochondria because it's mediating the apoptotic mechanism. So it's sort of, it's indirect evidence that apoptosis is occurring. And then when they gave this pegylated TNF-alpha receptor, which was mopping up all the TNF-alpha, you didn't see any red. It doesn't really show there at all, but basically all the red went away so that you're blunting, hopefully, the apoptotic pathway. And the whole point in the paper they talk about is that if you could do that, you'd basically preserve nephron mass until you were able to do something definitively for the problem. So then looking at the evidence now, that's probably a misplaced slide, but a little brief blurb on the UPJ obstruction. So the number one cause now of congenital hydro after the transit physiologic is 1 in 1,500 live births. It's number one cause after, like I said that, there's a male and left side predominance, and then it can be bilateral in 10 to 40%. And so the presentation can be anything from antenatally, which is very common now, and we see people in the clinic, to how they used to present if you didn't have this, which was with recurrent infections, back pain, abdominal mass, hematuria. And then there were 2 studies that showed that under the age of 6, actually presenting with pain was unlikely. And there's a sort of phenomenon called Beadle's crisis where there's this transient kind of UPJ obstruction in a sense, where the kid comes in with pain, you do an ultrasound, you see what looks like a UPJ obstruction, they get better, you follow up with another ultrasound and it's gone. And then they kind of come back again with more pain, it's this transient thing. So, but unlikely unless you're older than 6. And then this is looking at the pathology, so when we go in and we cut out that obstruction and you send it to the pathologist, this is looking at what they were saying they found on the pathology specimen. So earlier it seems like an intrinsic narrowing was kind of the explanatory thing. And then as you got older, the specimen was older, it was less so. But the crossing vessel became more likely. And so we always think of it as being like, you kind of see both or a combination of both. But interestingly enough, it seems like it changes, or the prevalence is different depending on your age. And so looking at the 3rd trimester, I showed you this similar slide which showed this breakdown in the 3rd trimester ultrasound. And then what's the likelihood of having a pathology? And it was like 12, 40, and 80% or 90%. This is just actually looking at what's the probability then that it's a UPJ obstruction. So you can kind of correlate that to the AP diameter. And then you can see that, you can see that it's like a toss of a coin if they fit in that severe category. So kind of interesting. The other question is then, so does everyone present antenatally? And this is sort of, it's all over the place, but this was a paper in the early 90s where 95 consecutive pyeloplasties, and the presentation was other than with an antenatal hydrodiagnosis in 75%. And so everything from just incidental to abdominal pain, UTI, mass, gross hematuria, kind of like they used to present traditionally before you had this imaging. And there's a paper 5 years later where basically it was the inverse of that, so the opposite story, where of 79, only 21 actually presented with pain or UTI or incidentally. So it's a bit of a moving target maybe because of the fact that we're doing ultrasound now. This is just a quick, this was an American study, but they were just trying to discriminate, like how do we know who we exposed to all this radiation doing MEG3s and the intensity of the workup, and they showed that they wanted to make it a cost-effective thing. So they actually, and this is sort of reflective, I guess, a bit in the guidelines too, but they would look at the AP diameter. If it was more than 15 millimeters, so they fit in the severe category on their 3rd trimester, then it discriminated obstruction in 80%. And so it's not a perfect sensitivity or specificity, but if you did that, you could break this down that children with that had a 4-fold likelihood of having a UPJ obstruction relative to people who didn't. And that they used that to rationalize their follow-up. So they would do an ultrasound and a MEG3 every 3 months until 1 year old, which is quite a bit, versus nothing. And then they did the math in the States showing that you saved $8,000 per patient lifetime. So the next question is then, if we have this, and what's the natural history of it? So what if you just do nothing? And if you have, this is where the dichotomy in the guidelines kind of exists too, and you see this, is that for grade 1 and grade 2, this is the SFU grading, the spontaneous resolution rate actually at 12 months was pretty good. And that's only at 12 months. And of those, none of them actually progressed or required surgery. They just may not have resolved. And then, so what if you take that same group, or same grading, sorry, and you just wait longer? So now they waited 142 months, and the spontaneous resolution rate went even higher, so 92% for grade 1, and then 87% of grade 2 were stable or improved. So that's pretty good. So it's almost, you don't say it's kind of like the rule in the sense that they should get better and you can follow them comfortably without worrying that you're wrecking their kidneys. And then, but it's the different story for the SFU 3s and 4s. So the spontaneous resolution rate kind of drops significantly. And so, and then the next thing is, what if you really do nothing? Not only do you not operate on them, but you don't even give them antibiotic prophylaxis. And this was, there's actually never been a randomized controlled trial that's put people into prophylaxis or not with UPJ obstruction. And the rates of UTIs are kind of all over the place, anywhere from sort of 2 to 30% with observation. And so, and the kind of interesting thing is that 2 studies show a similar infection rate, which is very low, and it didn't matter if you gave antibiotics or not, it was the same. So that's kind of interesting. And then, and this is one of the studies showing a very low infection rate, which is nice to know if you're not giving prophylaxis, because these were SFU4s, so they're pretty severe. There wasn't reflux, and they kind of looked like they had an obstructive pattern, no antibiotics, and they followed them for 27 months. They only had a UTI in 1 patient, which is a lot lower than what we found, but very low. And then the next study was kind of confusing because this is people with a UPJ obstruction again. If the last group was SFU4 on severity, then hard to say, but probably a similar group, and they weren't circumcised. They were given cephalexin and TMP, and at 24 months, they had a 25% febrile UTI rate with antibiotics, which is kind of confusing. So that's kind of, there's no real, the evidence is kind of weak. And then we looked at this and basically showed that the overall we had kind of an 18 to 20% infection rate, UTI rate, but the febrile UTI rate was very low. Like it was For mild and moderate, I think it was around 4% or 3%, and then for the severe, it went up to 10%. But it's very hard to pick that out of what's going on in the patient's chart, and that's documented and everything. But so we actually don't give antibiotics unless they present with infection, and then we do. So what should you use? This is just sort of in general. This is dose dependent, or weight dependent. But these are the two antibiotics that are most commonly used. Let's get that. So looking now at the evidence, what's sort of driving the guidelines? There's actually never been a randomized controlled trial to show benefit of surgery over observation in preserving function. And so the natural history finding is that 39% of patients that are observed will have a variable function loss down the road, anywhere from 5 to 40%, which is pretty much catastrophic. And after a pyeloplasty, really what you're doing is you're blunting that loss. So the range is kind of 0 to 6%. And I think initially I always thought that you would like get that function back, and you do your scan for differential function, it would be back up to 50-50. But the majority have less than 10% improvement after pyeloplasty. So you have to almost brace yourself for that. And what you're trying to get is drainage and blunt the loss. And so there's only actually 2 studies that show a benefit of pyeloplasty versus observation, and the outcome in those was actually colic. So there's some special circumstances. So Ransley did this important study in the 1990s, which helps in counseling patients and making decisions, because he looked at people, the majority of these people, the overwhelming majority, were in the moderate category. And that's kind of that gray area where it's hard to decide. But they all had good function still. So, you could take the argument that you should preemptively do something for these kids because you want to try and head off the problem. Or you can make the argument that, well, maybe they don't need to have anything done, and the natural history will be that they'll resolve or not get worse. And so that's what he kind of did. He had no regard for washout curves, so he just looked at moderate, they were mostly moderate, looked at function. If it was good, he had 100 people that he just watched. And of that, at the end of the day, almost a quarter of those people went on to have a pyeloplasty. But it wasn't always because the function was declining. Of that 23%, 14% was because the function was nowhere to go down. But only 5% of that total was because, or actually lost function, so it was not recoverable. So in counseling, you say well, we can probably watch. There's a you have to have close follow-up. There's a 0.25% chance that you're going to have to do surgery. Sorry, a 25% chance you have to do surgery. And then there's a 5% chance in doing that. So everything's always a risk reward kind of thing, that you may actually lose kidney function. And then there's other reasons too why they had to go on to have a pyeloplasty. And sometimes it was just UTI or pyelo, pain, polyuria, non-compliance, that kind of thing. So that study's always quoted quite a bit. And then if you did have surgery or need a pyeloplasty, all of them were, the AP diameter was, when you look back, they actually were over 12 millimeters. So kind of the higher end of the moderate. And at the 1 month, this is postnatal. And then most of the repairs were done within the first 3 years. And then so, again, who do you fix antenatally? There's this thing about people, there's a misconception that the vesical amniotic shunt is going to help with your kidney development, but it's actually probably already too late. And if anything, you're just preventing pulmonary hypoplasia. So that's kind of not really significant for us. Postnatally, though, there's still really no consensus. But we do have the CUA guidelines, which I showed. So then I just have a couple of interesting kind of thoughts or cases, because there's Ransley in the same sort of time period in the 1990s had a study where it was a series where he looked at people with a UPJ obstruction, and then he did their function, and they had less than 10%. And most people kind of reflexively say, well, that kidney's shot, you should probably take it out. And so he actually, this is neat because these were asymptomatic people. It was prospective, put in nephrostomy tubes, and then 9 kidneys, so it's not very big, but tubes for 3 weeks. And then he would repeat it and do a nephrectomy if your renal function was less than 10%. They had proven that was useless. And he actually had 2 that improved, so 2 out of the 9, and 1 was 19 and 1 was 41%. So, this was like a big success, I guess, but still at the same time, it was 1 out of 9 kidneys. And so probably didn't really argue very strongly that this was the way to manage them. But then if you looked at this little cohort, there's actually 2 little papers here, but this was retrospective. These were actually different, though, because these were symptomatic UPJ obstructions, so they weren't these antenatal diagnoses that were followed prospectively. And so they might have been an older group. And I'll show you something in a second that says that perhaps if you're older and you present that way, you're less likely to have dysplasia or severe dysplasia, and you might have a better kidney at the end of the day. But nonetheless, they were given nephrostomy tubes for 4 to 6 weeks. Mean age was sort of anywhere, well, it's 5, but from 2 months to 11 years old. And this is amazing because basically in 70 and 100%, the function improved to a mean of greater than 30%. And then they went on to subsequently have a pyeloplasty. So that's actually kind of the complete opposite. It's pretty impressive. And then we have in Edmonton, a lot of the surgeons well, the two surgeons, the pediatric surgeons, both have these anecdotal studies of where they've done that, where they did it out of necessity, put a nephrostomy tube in, and then the kidney function dramatically got better, and they kind of and they're just basically one of them when they were able to pull the tube out, and the kid was fine. And probably if you didn't do that, you would have been committed to taking out the kidney. So surgical outcomes just quickly. So you can do this open, you can do it lap, or you can do it robotically. And at the end of the day, the bottom line is that obviously the minimally invasive, like everything else, is always less pain. They're out of hospital faster, but it's more expensive. And robotic, I've actually never seen a robotic pyeloplasty in a peds patient. But and then the humbling thing. So this is kind of probably the important slide that sometimes when you do your pyeloplasty and then you look down the road, you have to see them in follow up, and you expect it to just look perfect, and then you do your ultrasound, and you have to know that when you look at the studies, the mean SFU grade decrease is only 1. And so they're still going to have this hydronephrotic kidney, basically. So you can't be discouraged by that. To see resolution to an SFU 0 or 1, which is pretty much perfect, we actually see it in less than 20%. But 64% of people will have a decrease. So that's nice. Oops. The one thing, though, is if you follow these guys out even longer, so if you look at follow-up greater than a year, the only parameter that was improved was drainage. But that's okay, because that's kind of why you did it, and so you're happy. So 98% with a T half-life of that radiotracer is less than 20 minutes. That's pretty good. And then the one thing, too, that's interesting is that we know that if the diagnosis is antenatally, the functional improvement is 2.5% less. And then if your diagnosis is postnatally, it's 5%. So maybe it's a difference in the severity. And then so this is just a quick slide on failure when you're counseling patients. So in 3 series, it's less than 7%. We did a dismembered pyeloplasty. It wasn't any different depending on what modality you used. And the mean age was kind of 13 to 26 months. The reasons being fibrosis or redundant pelvis or adhesions. And the nice thing is that if you do a reoperative pyeloplasty, the success rate was still 90 to 100%, and you can still have the option of doing endopylotomies with a reasonably good success rate. So there's kind of a way out, which is nice. That's it. Yeah.